Hi, my name is Dyan, and we will be presenting to you a case study of cerebral palsy along with my group mates Sonakshi, Smriti, and Khushi. Jane is a 12-year-old girl diagnosed with spastic diplegic cerebral palsy at 2 years of age. Jane lives in Melbourne with her parents and the only daughter of Sarah and James. Sarah is Jane's primary caregiver, managing her daily needs and medical appointments, while James is employed full time as a construction worker and provides supports when he can. For Isbar handover, Jane is a 12-year-old girl with supportive parents. Situation Jane presents to Swinburne Hospital Emergency Department with a chief complaint of increased muscle stiffness and difficulty in breathing. Past medical history, she's born premature at 28 weeks, faced NICU for 2 months due to respiratory distress and intraventricular hemorrhage. Developmental delays sitting at 18 months and walking at 4 years. Delayed speech but normal intelligence. She's now dealing with scoliosis and recurrent respiratory infections and no other significant medical history. For assessment, CNS and CVS, there's no abnormality detected. Presence of respiratory distress, her respiratory rate is 25 breaths per minute. Increased work of breathing, nasal flaring, use of accessory muscles. For GIT, bowel sounds are normal and active. Presence of moderate siluria, pulling posteriorly. Renal and tegumentary, no abnormality detected. Musculoskeletal, trouble controlling voluntary movements, particularly in lower extremities, leading to spasticity and muscle weakness. Difficulties in maintaining balance and coordination. Spastic gait pattern, muscle hypertonia in the lower extremities, hyperactive deep tendon reflexes, contractures in the ankle and knee joints, ambulating independently for short distances, pushes his manual wheelchair for long distances. For social supportive family, you are assigned to the AM shift and Jane is one of your allocated patients. Please continue managing her respiratory distress and symptoms of muscle weakness or stiffness. Clinical manifestation of cerebral palsy. First is intellectual disability. This affects 30 to 50% of individuals with cerebral palsy. Next is bone health issues, such as spinal deformities like scoliosis and osteoarthritis, which can even result to hip dislocation or bone injuries. Next is speech disorder and language disorders or dysarthria. Next, seizure disorder, impaired vision, for example, strabismus or crossed eyes, dysphagia, which is difficulty in swallowing, and sialorrhea, which is excessive drooling. Next is delayed growth and development. Children with moderate to severe cerebral palsy often lag in growth and development. Next is hearing loss, which can be as a result of jaundice or lack of oxygen to the developing brain. Last, higher risk of developing heart and lung disease such as pneumonia.
Now let's move on to the epidemiology of cerebral palsy. Cerebral palsy is one of the most common childhood motor disabilities. Its prevalence varies globally, but it's estimated to affect around 2 to 4 per thousand live births worldwide. However, this prevalence can differ significantly by region, with some areas reporting higher rates due to factors such as access to healthcare, maternal health, and socioeconomic status. The incidence of cerebral palsy is influenced by various factors, including gestational age, birth weight, and perinatal complications. For instance, the risk of cerebral palsy increases with decreasing gestational age and lower birth weight. Babies born prematurely are at higher risk, with approximately 10 to 15% of cases of cerebral palsy occurring in preterm infants. Now, here are some facts about epidemiology of cerebral palsy. Moving on to the types of cerebral palsy, there are three main types. The first one is dyskinetic cerebral palsy. It is characterized by involuntary, uncontrolled movements which can be slow and writhing or rapid or jerky. These movements can affect the face, trunk, and limbs and may interfere with voluntary movements. The pathophysiology associated with it is that it often results from damage to basal ganglia or other parts of the brain involved in controlling movements. The basal ganglia play a crucial role in regulating muscle tone and coordinating movements. Damage to these areas disrupts the normal control of muscle movements, leading to the characteristic dyskinetic movements of basal ganglia. Causes of basal ganglia damage may include perinatal asphyxia, brain infections, or genetic disorders. The second one is ataxic cerebral palsy. It is characterized by poor coordination, shaky movements, and difficulties with balance and depth perception. People with ataxic cerebral palsy may have a wide based gait and tremors, make fine motor tasks challenging. Its pathophysiology is often associated with damage to cerebellum, a part of the brain that plays a central role in coordinating movements and maintaining balance. Damage to the cerebellum disrupts its ability to integrate sensory information and coordinate muscle movements accurately, resulting in the characteristic symptoms of ataxic cerebral palsy. Causes of cerebellar damage may include prenatal brain malformations, perinatal brain injury, or genetic factors. The third one is spastic cerebral palsy. It is the most common type, characterized by increased muscle tone and stiffness, leading to stiff, jerky movements. This stiffness primarily affects the muscle of the limbs, making movements difficult and sometimes causing contractures. Pathophysiology associated with spastic cerebral palsy is that it results from damage to the motor cortex or corticospinal tracts in the brain. This damage disrupts the normal signaling between the brain and muscles, leading to an imbalance in muscle tone. As a result, affected muscles become overly stiff and resistant to movement. The exact cause of the brain damage can vary, including factors such as prenatal brain injury, perinatal hypoxia, ischemia, or postnatal brain injury. Moving on to the pathophysiology associated with Jane's presentation. Increased muscle stiffness and respiratory distress. Jane's respiratory distress and increased muscle stiffness align with the underlying spasticity characteristic of spastic cerebral palsy. The increased muscle stiffness can affect respiratory muscles, impairing chest wall movement and leading to respiratory distress. The second one is developmental delays. Jane's development delays, including delayed sitting and walking independently, are consistent with the impact of cerebral palsy on motor function and coordination. Damage to the developing brain in cerebral palsy affects areas responsible for motor control and coordination. This disruption leads to difficulties in achieving developmental milestones at the expected age, such as sitting and walking. History of recurrent respiratory infections. The history of recurrent respiratory infections reflects the respiratory vulnerability associated with cerebral palsy. Her compromised respiratory function and susceptibility to infections contribute to her clinical presentation of respiratory distress on exacerbations. Individuals with cerebral palsy are at increased risk of respiratory complications due to weakened respiratory muscles, impaired cough reflex, and difficulty with airway clearance. Overall, Jane's clinical presentation is closely tied to the pathophysiology of spastic cerebral palsy, which affects her motor function, musculoskeletal integrity, and respiratory status. Understanding these relationships is crucial for providing tailored management and support to address her specific needs and optimize her quality of life.
Implications of cerebral palsy. Physical, cognitive, and social development in children all can be greatly impacted by cerebral palsy. A number of developmental consequences are evident from the case study of Jane, a young child with spastic diplegic cerebral palsy. Now we'll talk about all the implications of cerebral palsy. Physical development. Children with muscular rigidity and spasticity, such as Jane, frequently have limited movement. Cerebral palsy is also defined as a condition of movement and posture. Walking, crawling, and sitting become delayed as a result of this. Jane's usage of a walker by the time she was 4 years old and her issues with motor control are suggestive of those difficulties. Due to reduced mobility and physical activity, the result can be respiratory distress as seen in Jane, reduced lung capacity and impaired gas exchange. Next is the cognitive development. While not all children with cerebral palsy undergo intellectual disability, those who do, such as Jane, encounter difficulties with learning, solving problems, and other cognitive tasks. Their academic development may be impacted, necessitating modifications to the teaching strategies and learning conditions. Social and emotional development. Social relationships and emotional well being may be impacted by the physical and cognitive obstacles because of their peculiarities or the first fact that they are unable to engage in some activities with their peers. Children with cerebral palsy may feel alone. Possible problem with psychosocial and developmental concerns with self-esteem. As Jane matures, she can become more conscious of her physical limits in comparison to her friends, which could result in poor self-esteem or feelings of inferiority. Next, dependency and autonomy. Jane may find it more difficult to gain independence as a result of her reliance on carers for everyday tasks and movement. Social isolation. Jane may become socially isolated from her peers as a result of her inability to participate in physical activities, which will affect her capacity to make friends and socialize. Next, we'll discuss about the three goals. First goal is to improve physical function and respiratory distress, and the action taken can be to control spasticity and enhance motor abilities, conduct routine physical therapy, promote the involvement of people in adaptive supports and activities. For respiratory distress, oxygen levels should be monitored, providing supplemental oxygen as prescribed to achieve the target levels. Also maintaining the posture for a clear aim. Second goal is to encourage educational and cognitive growth, and the action can be work together with educational specialists to modify instruction to meet Jane's cognitive demand, to improve learning, make use of assistive technology. The last goal is to promote emotional health and social contact. Intervention can be lead peer support groups or arrange get-togethers with individuals facing comparable difficulties. Counseling and psychological help should be given to meet emotional requirements. The nurse function in encouraging family-centered care. First, teaching the family, informing the family about the demands of the child's care and the implication of cerebral palsy is a critical job for nurses. This involves receiving instruction on meeting the child's physical requirement as well as offering emotional support. Next, family empowerment. Give your family the tools they need to actively participate in care decisions. This entails honoring cultural values, family dynamics, and their awareness of the child's needs. Next, care coordination. To guarantee all developmental aspects are covered, nurses should organize multidisciplinary care involving pediatricians, therapists, and educational specialists. Recognize the stress and emotional load that family members may be under and offer them emotional support. It can be helpful to provide resources for counseling and respite care. Through the implementation of these measures, nurses may make a substantial difference in the quality of life for kids with cerebral palsy, such as Jane and her family, enabling them to have happy, meaningful life in spite of their condition. To address the problem and alleviate burden for families, the Comprehensive Cerebral Palsy Program implemented a nurse-led comprehensive interdisciplinary team approach to provide optimal care coordination to patients and families using an integrative holistic care plan. During an annual 3 to 4 hour comprehensive
Moving on to
cerebral
nursing interventions, the two picked for Jane are managing her drooling and muscle stiffness cerebral palsy holistically. One of Jane's presenting issues is her difficulty breathing and respiratory distress, so her goal here is to improve her respiratory function. The intervention picked for this goal is to manage her posterior drooling. Drooling is a common issue in children with cerebral palsy, like Jane. It can be caused by a variety of factors, including abnormalities in swallowing, poor mouth closure, joint stability, tongue thrusting, lack of head control, and poor posture, among others. In Jane's case, this excess saliva drains on the back of her tongue into her airways and lungs instead of going into her stomach. This situation may cause recurrent chest infections and can lead to permanent lung damage. This type of drooling, called posterior drooling, results in the secretions pooling around the hypopharynx, thereby increasing the risk of aspiration pneumonia. Therefore, the first step here is managing the issue by looking at the signs of aspiration, such as coughing, wheezing, choking, changes in voice and respiratory rate, increased secretions, unexplained fevers, decreased oxygen saturation, and alertness decreasing, especially during feeding. Actions required for this intervention, beginning with positioning. In Jane's case, supporting or stabilizing her head is crucial to ensure an upright position. This simple measure can facilitate the flow of saliva into her esophagus, alleviating issues associated with saliva pooling in her airways. Positioning her in a semi-phallus position can also help with lung expansion, as lung compliance is usually decreased in kids with cerebral palsy. Encouraging her to clear her throat by coughing is vital, as this can help clear her airways. This is particularly relevant with Jane, as children with cerebral palsy often struggle with coughing and certain defense mechanisms, which can worsen respiratory distress. However, if Jane's cough is actually weak or non existent, then we might need to resort to suctioning. Hence, ensuring that suction equipment is readily available becomes an essential part of this intervention. Another interesting approach is the use of swallow reminder devices. These devices are designed to provide external cues to aid deliberate swallowing, as swallowing can reduce the risk of this saliva getting into our airways. Considering Jane's status as an adolescent with developmental issues, she might need these extra cues, in contrast to a child without cerebral palsy. Now let's touch on the topic of basic hygiene. It is paramount that we provide Jane with the tools and knowledge to maintain her personal hygiene. We could consider providing her with bibs if necessary and teaching her how to clean up when required. These efforts serve a dual purpose. They not only help her keep clean, but also foster her confidence and autonomy. Collaborating with a speech therapist can prove to be advantageous, as they can guide us in providing Jane with textured food and fluids during a hospital stay to reduce her risk of aspiration. This approach is significant as sialaria and can cause swallowing difficulties and potentially lead to aspiration. Oxygen supplementation. If Jane is having too much trouble with keeping up her oxygen saturation, or if it's dropping too rapidly, administering at least 2 liters of oxygen via nasal prongs and monitoring her respiratory health can be beneficial. How do we evaluate the outcomes? An improvement in Jane's work of breathing, her oxygen saturation, her respiratory rate, and management of her drooling by maintaining comprehensive records of it will give us a very good idea of her improvement. Another issue at hand is Jane's muscle stiffness. Our immediate nursing intervention is to provide relief and manage the short term symptoms effectively. Techniques to aid this muscle stiffness include heat and cold therapy. Cold therapy can provide temporary relief from spastic muscles, although this relief may only last for about half an hour to an hour after application. Paradoxically, heat has also been proven to relax tense muscles for people with cerebral palsy. Massaging and muscle stretching techniques prevent contractions, promote muscle growth, and also relieve rigidity. These therapies also alleviate pain, which can be a significant issue for some. In addition to medications, pain can also be managed through distraction techniques in Jane's case, using methods such as showing something interesting on the television or providing her toys to play with. Unfortunately, there is no cure for cerebral palsy, but effective symptom management can greatly improve quality of life. In regards to long term actions for children like Jane, they and their families are encouraged to seek assistance from NDIS, which is the National Disability Insurance Scheme. As it is evident from her admitting diagnosis, recurrent infections, and drooling that there isn't enough healthcare support for Jane. The NDIS funds several critical services for people with cerebral palsy, including a multidisciplinary team that looks at patients more holistically, rather than just focusing on problem areas such as muscle stiffness. How will we evaluate our outcomes from the short term actions we take? Firstly, monitoring relief in muscle stiffness and pain after heat and cold therapy, noting the duration of relief, and noting down what works best for Jane. Observing Jane's response to distraction techniques based on her engagement time and any changes in reported pain. assessing changes in muscle tension, flexibility, or range after massaging or stretching exercises, and checking Jane's comfort level and overall well being after each interaction, and looking for signs of relaxation and improved mood. In conclusion, managing a case of cerebral palsy is complex, as illustrated by Jane's situation, and it requires a comprehensive interdisciplinary approach. It is crucial to address the physical, emotional, cognitive, and social aspects of this condition while promoting the individual's overall quality of life. From managing respiratory distress to supporting educational growth, each intervention plays a significant role. The focus on family centered care, teaching the family, empowering them, and coordinating care is essential for ensuring continuity of care and optimal outcomes. Ultimately, the goal is to help individuals with cerebral palsy lead a fulfilling life despite their diagnosis. Thank you.